Ladies and gentlemen, thank you for joining the Lake Superior Quality Innovation Network, Immunizations and Antibiotic Stewardship webinar. Your host, Aparna Ghoshmi, will now begin.
Good afternoon and welcome to today's webinar presented by Lake Superior Quality Innovation Network. Lake Superior QIN is comprised of three organizations, MPRO in Michigan, Medistar in Wisconsin, and Stratus Health in Minnesota, to support the Centers for Medicare and Medicaid Services priorities for healthcare quality improvement in each organization's respective state. Today's webinar slides will be available on our Lake Superior QIN YouTube page within the next week. I would like to introduce you to today's speaker, Dr. Michael Klepser. Dr. Klepser received his Doctor of Pharmacy from the University of Michigan College of Pharmacy in 1992. He has also completed a pharmacy practice residency at the Detroit Receiving Hospital and University Health Center and a fellowship in infectious diseases at Hartford Hospital in Hartford, Connecticut. Dr. Klepser has been a professor of pharmacy at Ferris State University since 2001. Prior to joining Ferris, he was an associate professor at the University of Iowa College of Pharmacy from 1995 to 2001. Dr. Klepser's research interests include use of point-of-care tests in community pharmacies, community-based antimicrobial stewardship, antifungal pharmacotherapy, antibacterial and antifungal pharmacokinetics and pharmacodynamics, influenza, and health economics. He has published extensively on these topics and has more than 130 peer-reviewed manuscripts to his credit. Dr. Klepser is a founder and content advisor for the Community Pharmacy-Based Point-of-Care Testing Certificate Program. He is active in several professional organizations, including the Society of Infectious Diseases Pharmacists, the American College of Clinical Pharmacy, and the Infectious Diseases Society of America. We're really excited to have him today, and at this time, I would like to turn it over to Dr. Michael Klepser.
Thank you very much for that introduction. Without further ado, I guess we'll get into this topic. And really this whole idea of community antimicrobial stewardship really took off a few years ago with the publication of a few documents from the White House looking at improving antibiotic utilization rates and decreasing bacterial resistance. And then took another little bit of a stimulus back in November when the CDC published their core elements for conducting community antimicrobial stewardship. And so what I want to do today is spend some time describing the rationale behind community antimicrobial stewardship, list some of the drivers of antibiotic use in the outpatient setting, list the core elements as published by the CDC for community antimicrobial stewardship programs, and then finally discuss how immunizations are really linked to antimicrobial stewardship and what role they play in this endeavor. First, just kind of setting the stage for outpatient antibiotic use. It's estimated that there are approximately 500 or 450 million physician office visits that occur in the United States every year. And of these, more than 150 million result in giving the patient a prescription for an antibiotic. And if you play with the numbers and translate this, and various investigators have shown this, that anywhere from 60 to 80% of the outpatient or of the use of antibiotics in human occurs in the outpatient setting. And unfortunately, hand in hand with this are several reports that have documented that there are high rates of overuse and misuse. In fact, that some individuals, especially those with upper respiratory tract infections, receive antibiotics when they're not necessary. For instance, 80% of adults with rhinosinusitis and greater than 60 to 80% of adults with acute pharyngitis receive antibiotics. And we know that this is a inappropriate percentage. So taking pharyngitis, for instance, even in the adult population, we know that group A strep accounts for pharyngitis in only 5 to 15% of adult patients. And then contrast that with the greater than 60% of adults that receive antibiotics, you can see that there is a remarkable disconnect between these numbers. If we look at antibiotic use across the country, we find some alarming data. In 2013, Lori Hicks and colleagues from the CDC published a report on 2010 usage data of antibiotics in the United States. and they found that the national average, there were 833 antibiotic prescriptions per 1,000 individuals. So, just at first glance, this means that almost over three-quarters of individuals are likely to receive an antibiotic at any given point in time. This figure varies greatly from state to state, but again, the thought being that at least a good percentage, 30 to 50% of those antibiotics that are being prescribed are most likely unwarranted. If we look at who the individuals are that are prescribing antibiotics on the outpatient setting, it really shouldn't come as much of a surprise that it's predominantly primary care physicians and nurse practitioners and physician's assistants. And this is important to understand because when we talk about developing antimicrobial stewardship initiatives, we need to target areas where we're going to have the greatest impact. So even though there's a lot of individuals who talk about emergency department use and dental use of antibiotics, you can see that independently those account for 5% and 9% of antibiotic prescribing in the outpatient setting, respectively. So if you were going to dedicate resources and try to have the greatest impact, this might not be the greatest area for you to try to impact initially. In terms of some more data on the antibiotic use, of the antibiotic use in the community, 50% has been determined to be inappropriate, whether it be the wrong drug for a indication, whether that antibiotic is needed, or if it is a drug that's not recommended by treatment guidelines, or the antibiotic is prescribed at the wrong dose and duration, resulting in overexposure or underexposure of the patient to the agent. And if we look further, I talked about some of those indications for which antibiotics are not warranted. More than 25% of antibiotics are routinely prescribed for conditions such as acute bronchitis, acute sinusitis, acute pharyngitis, areas where the likelihood of bacterial pathogen is fairly uncommon. In fact, there was one study done in a nursing home that found roughly 40 to 50% of residents had received an antibiotic for the common cold. Now, it's not saying, these data are not indicating that, all individuals are equally responsible for this problem that we've got with antibiotic overuse. However, again, globally, you can see that a majority of the visits that occur in physician offices for acute conditions result in the patient receiving an antibiotic. Roughly 3/4 of visits result in an antibiotic being prescribed. And it was found that in one study, when you compared the providers with the highest prescribing rate to those with the lowest prescribing rates, those in the highest 10% of antibiotic prescribing prescribed antibiotics during at least 95% of their visits, contrasting with the lowest 10% which prescribed antibiotics in less than 40% or fewer of their visits. So again, there's a tremendous amount of variability among prescribers contributing to this problem. Well, on a positive note, if we look at some data comparing antibiotic prescribing rates for select infections or for select processes from the 90s to the 2000s, you can see that in general our prescribing rates have gone down. If you want to take a more pragmatic view of these, or a more pessimistic view, you can argue that, for something like the cold, yes, our prescribing rates for antibiotics went down from 52% to 37%, but then you can ask, why are 37% of patients receiving antibiotics for the common cold? Likewise, some of the similar prescribing rates for bronchitis, sore throats, and sinusitis are probably still unnecessarily high. So if we look at the United States today and look at some of the outpatient surveillance data that was analyzed by Catherine Fleming-Durtha from the CDC, they noted that about 13% of all outpatient visits, so these are not just primary care visits or whatnot, these are all outpatient visits, resulted in an antibiotic prescription. And again, looking at high-use conditions, they found that acute respiratory conditions were one of the most common reasons why prescribers provided their patients with an antibiotic, and that occurred in about 44% of visits. And they did note that, unfortunately, a lot of these conditions were caused by viruses for which then antibiotics would not be appropriate. Again, looking at antibiotic prescribing kind of by indication, they estimated that patients with acute sinus infections, there were approximately 6 million unnecessary prescriptions that were dispensed each year, 8 million unnecessary prescriptions for viral upper respiratory tract infections or the cold, and 2.5 million unnecessary prescriptions for middle ear infections. So again, relatively mild self-limiting diseases or those caused by viruses for the most part. So now we need to step back and start to consider why we've created an environment in which antibiotics are used so indiscriminately in the outpatient setting. And, you know, one of the primary factors historically that's been pointed to was the belief that if a patient comes in with an acute illness that they believe is infectious in nature, that they demand or expect an antibiotic. And I believe that this falsely has driven a lot of prescribers into dispensing or prescribing antibiotics. Recent data suggests that that patient expectation is not as great as previously thought, and that patient satisfaction secondary to office visits is not necessarily linked to receipt of an antibiotic, but upon the perception that the provider cared about them and listened to their signs and symptoms and did what they believed was in their best interest. Another driver is prescriber lack or familiarity with treatment and immunization guidelines. This is a big one. There are a number of treatment guidelines that are published on a regular basis. And unfortunately, in general practice, many prescribers just are not able to keep abreast of the most recent recommendations. A lot of recommendations which get into lengths of treatment, selection of agents, diagnostic tests that would promote or curb the inappropriate use of antibiotics. So there's a lot of gaps in prescriber knowledge with respect to these guidelines. Also, if we look across various studies and databases, we find that prescribers generally do not use appropriate diagnostic tests when looking to make a diagnosis in their office. Currently, there are a number of clear wave point-of-care tests that are available for a variety of conditions, including strep throat, influenza, and a number of other indications that are available that have good sensitivities and specificities that are recommended for use by treatment guidelines. But when we look at individual patient data, we fail to see in a lot of cases where a prescriber actually ordered one of these tests to support a diagnosis. Additionally, there are many episodes or evidence to support the fact that even in the presence of a negative test, many prescribers choose to ignore the data and prescribe antibiotics inappropriately in that situation as well. There's also belief that the provider shortage which we've experienced may be contributing to some of this misuse of antibiotics. The belief being that there are pressures to see more and more patients, and the provider can spend less time, is able to spend less time with the patient. From that standpoint, then they tend to prescribe antibiotics in lieu of that inability to spend the time with the patient. Dismiss and done. Typically in office practices, once a patient comes in and seen for an infection, or infectious episode or possibly infectious episode, there's little follow-up for the patient, and that typically the patient is seen, dispense an antibiotic or not dispense an antibiotic, and left to their own accord. I think that there'd be greater willingness to use delayed prescribing practices if there were safety nets put in place to provide patients guidance and to use those therapies and not leave the patient making a lot of medical decisions on their own. There's a lot of free antibiotic programs that are out there that are being promoted by a number of pharmacies. I believe that these were initially well-intended programs, but what's happened, especially in underinsured populations, is that prescribers and patients become aware of these programs and tend to prescribe these select antibiotics, preferentially, even if that means that that specific antibiotic is not necessarily the drug of choice or the recommended agent, per the guidelines. And this results in, creating pressure by the use of suboptimal antimicrobials that may not be appropriate for a given resistance or susceptibility profiles. And then lastly, there's fear. We've created an environment in the United States where there's a fear of missing something, a fear of litigation. So again, it's kind of the cover your butt philosophy, and it's easier to prescribe something than to defend the action not to prescribe, and the fear that a patient might take legal action against the provider. Now, the problem of resistance, really cannot be understated. There's reports, now across the country of hand-resistant bacteria predominantly located in hospital settings, which are resistant to all known antibiotics. And these infections caused by these pathogens, have a tremendous impact on morbidity and mortality and costs associated with care. And likewise, antibiotic use and resistance in the community has also been documented. There were several studies which were done in Scandinavia looking at prescribing patterns of outpatient antibiotics such as the macrolides. And these investigators found nice correlations that demonstrated links between increased use of macrolides and increased rates of resistance among Streptococcus pneumoniae community isolates. And similarly, when they restricted on a nationwide basis antimicrobial usage, those resistance rates went down. In addition, just to the emergence of resistance, again, looking at that morbidity and mortality, there is a significant increased mortality associated with infectious processes because it delays the prescribing of the appropriate antibiotic for a patient. This then, in turn, results in an approximated $20 billion in excess treatment costs annually in the United States. And then additionally, it further propagates resistance because as the specter of resistance is there and real, in the outpatient setting, clinicians then drift toward agents with broader spectrum of coverage. In addition to these bacterial and patient-related factors related directly to the infection, there are some clinicians that mistakenly feel that some antibiotics are very safe, and that it's more of a risk not to prescribe than to prescribe these agents to patients because of the infectious process. However, if we look at drug-related adverse events, we find that antibiotic-associated drug adverse events are the most common cause for emergency department visits among individuals less than 18 years of age. So among pediatric patients, the rates of visitation to emergency departments for an adverse event secondary to the receipt of an antibiotic is quite common. Similarly, exposure to an antibiotic is responsible for 1 out of every 5 drug-related emergency department visits among all patients. So regardless of age, there's considerable risk for experiencing adverse events requiring individuals to be seen in emergency departments. And those range, obviously, from hypersensitivity reactions, drug-induced fever, and all the way up to things like Clostridium difficile infections. So these are the documents that I previously mentioned that were published by the White House. Back in 2014, 2015, papers on the National Strategy and National Action Plan for Combating Antibiotic-Resistant Bacteria were released by the White House. And what I'd like to do now is just walk through some of the goals which were outlined by these documents. And the first was to slow the spread of resistant bacteria and prevent the spread of resistant infections. And the way that was suggested that this occurs through public health programs and tracking of antibiotic resistance, in fostering antimicrobial stewardship in all healthcare settings, including the outpatient setting. And so this was really the first document ever that really strongly advocated for extending antimicrobial stewardship programs into the community setting. And with these initiatives were some goals. And the National Action Plan suggested that by 2020, they would like to see a curve in outpatient antibiotic use by 50% from 2010 levels. So that is a pretty audacious goal, or a big goal, to see a 50% reduction in inappropriate use in outpatient levels. Now, the problem that we have, though, in a lot of institutions is we don't know what our antibiotic usage was or the appropriateness of that usage back in 2010, nor do a lot of clinics know what it is now. So there's a lot of effort that needs to be put in surrounding describing antibiotic use in the outpatient setting. Now, one of the most interesting comments that I've seen regarding appropriate or inappropriate antibiotic use is the need for an antibiotic. And Catherine Fleming-Goethe and her group concluded in their assessment of antibiotic usage in clinics that the more times an individual is seen by a physician, the more likely a patient will get a prescription, which is kind of a thing. But when you think about it, that's important because if patients are in better state of health and are at decreased risk for experiencing an infection of any kind, viral, bacterial, whatever, they're less likely to go to a doctor. And if the patient's not at a doctor, they are not going to get a prescription for an antibiotic. So this is one of the best things that we can do to help curb inappropriate antibiotic use, is to keep patients well in other doctors' offices. I mentioned that the CDC published their core elements for antimicrobial stewardship in the outpatient setting. And in these guidelines, they outlined 4 core elements: commitment, action, tracking and reporting, and education and expertise. And they identified certain interventions that could be done at clinician and clinic and system levels to promote these various core elements. And among the core actions that they proposed was, again, preventing patients from needing to see a physician or going to the doctor. And this being accomplished by preventing the spread of resistance and promoting immunizations, hand washing, and appropriate use of antibiotics. So right in there, in terms of stopping the spread of not only resistance, but infections altogether, you can see that immunizations play a key role even in the CDC's plan for accomplishing antimicrobial stewardship. In terms of some of the suggestions that were made in these core elements, for clinicians, things just in terms of demonstrating their commitment by displaying public comments in support of stewardship. And for clinics and healthcare systems, committing their resources and their support for these types of activities and communicating with all clinic staffs to help set expectations around stewardship. In terms of action and policy, clinicians need to be practicing using evidence-based diagnostic criteria and treatment recommendations. If you recall, this is one of the major barriers to appropriate use of antibiotics because, clinicians just are not familiar with these guidelines and recommendations. One of the personal stories, or a couple personal stories that I can share, is that one of my daughters, my 3-year-old, had recurrent otitis media. She had undergone 2 episodes or rounds of antibiotic therapy within a 2-month period of time, and as we came back for the 3rd visit, the prescriber at that point in time was about to prescribe Bactrim for my daughter. And I looked at that individual and I said, no, you're not going to prescribe that. And we proceeded to get into a discussion about she believed that guidelines recommended the use of Bactrim for otitis media that has been refractory or resistant to multiple courses of antibiotics. And I immediately then pulled up these guidelines on my phone and showed them to her where it said, do not use Bactrim in this situation. Another one of my daughters was seen for urinary tract infection by her pediatrician in the office. And, the urinary tract infection in her was an uncomplicated episode, but still the provider prescribed her a 10-day course of antibiotics, which is conservatively 7 days longer than what she probably required at that point in time. So just the lack of familiarity and the need to improve that familiarity with guidelines is huge. And clinics and systems, really need to be willing to, allow their clinicians to be trained. Also, they need to provide communication skills and training for clinicians so they can help communicate decisions when not to use antibiotics among the patients. The next element is the tracking and reporting. And I mentioned that we're not great in our clinics currently in terms of tracking antibiotic usage. So at the moment, we're looking at using, clinicians' ability to self-evaluate their prescribing practices. Unfortunately, if you ask a physician or prescriber, do you prescribe antibiotics appropriately? They all nod their head yes. If you say, look at the individual sitting next to you, do they prescribe antibiotics appropriately? They all shake their head no. So maybe some of this self-evaluation isn't the strongest, in terms of being able to account for some of this inappropriate use, but at least it gets them thinking about, when they should and shouldn't, and perhaps using some of the accountable justification for when they actually use antimicrobials. And then education and expertise. Again, there's a lot of things that we can do both at the clinician and the clinic health systems levels to not only communicate pros and cons of antibiotics amongst each other, but also communicate these strategies to our patients, as well as help them realize the potential harms that are associated with antibiotic treatment, and educating the providers with that information as well. So some of you are probably familiar with inpatient antimicrobial stewardship, and as of January 1st of this year, the Joint Commission is currently requiring that all inpatient facilities have a program in place for monitoring antimicrobial stewardship or conducting antimicrobial stewardship. There are currently guidelines in the works by JACO and the Accreditation Association for Ambulatory Healthcare that are looking at implementing or providing similar recommendations for antimicrobial stewardship in the outpatient setting as well. So there will be a lot of impetus for folks to get on board with this outpatient stewardship programs. What I'd like to do now is just kind of break down antibiotic prescribing into 4 phases, because when we think about the process of antibiotic use and prescription in these phases, it can really help us identify where some of our greatest needs are, or some of our greatest opportunities for impacting outpatient antibiotic use. The first phase in the prescription continuum is that need to seek care, and that if a patient becomes sick and makes the decision to see a physician, then that are going to increase risks for appropriate and inappropriate antimicrobial prescribing. And some of the things that we can do to alter patient behavior and alter patients' need to seek care, one is educate them, provide them educational materials about bacteria and viruses and the common cold, signs and symptoms of when to seek care and when just to rest. We can promote adult vaccination programs. We know nationwide we are falling well short of our documented goals for adult vaccinations, even among high-risk patients. And this is probably one of the biggest things that we can do to help alter this need to seek care. We can also promote other wellness initiatives. We can put in post-discharge bridge calls, so patients that are discharged from the hospital, between the time that they're discharged and can get into their provider for a follow-up, a great percentage of patients may decompensate during that time. And if they're not followed up with, they may not seek care immediately, and as a result, they may require readmission based on a complication. And then lastly, there are a variety of models out there looking at collaborative pharmacy-based care, for some acute self-limiting infections or even some bacterial infections like group A strep pharyngitis and things like influenza, where the pharmacy can offer, based on the collaborative practice agreement with the provider, the ability to see a patient, conduct a physical assessment, run a ClearWave point-of-care test when appropriate, and then provide follow-up care to that patient, either through that collaborative practice agreement or through a telephone call to the patient's provider. And in these models, we have noted a reduction in overall antibiotic use for indications such as group A strep by more than 50%. The next step in this process is the decision to use and select an antibiotic. And these are areas where a lot of education is going to come into play. Education in the prescriber about guidelines and practice updates, providing feedback based on prospective audit, as well as educating physicians and prescribers on the benefits of using some of these CLIA-way point-of-care tests or CLIA requiring point-of-care tests. And then helping restrict the inappropriate use of some agents by creating formularies in the community, or even insurance-based or free antibiotic-based formularies to help avoid use of suboptimal antibiotics. The next step is the dispensing of an antibiotic. And the pharmacist, if they're aware of the indication, can serve as a quality control check for the process and double-check the choice of antibiotics selected as well as the dose. But then the pharmacist can also use this opportunity to educate the patient on appropriate steps that they can take to prevent similar infections from occurring in the future, such as the value of immunizations. And we know that when a patient is ill and feeling bad, they may be more susceptible to suggestion to receive a immunization at that point in time than they might be at other points in time. Also at this point in time, there's also a role for the pharmacist to discuss, compliance, obviously, with, the patient. And one of the things that appears to be changing is the comment that pharmacists always provide patients in terms of taking their antibiotic until it's gone. There's tending to be a shift that is likely to be supported by a variety of groups to encourage patients to stop taking antibiotics once they begin to feel better. The thought behind this being that if you shorten the course of the antibiotics, you'll decrease the selective pressure on the patient's own flora, as well as reduce the risk that the patient might experience an adverse drug reaction. So we'll have to stay tuned for that. And then lastly, the follow-up. It's important that once a patient is seen, that they're just not left to make decisions, on their own, but we need to support them. And this can be done just as a safety net to make sure that if an antibiotic was not prescribed, that the patient's signs and symptoms did not worsen, or if they were prescribed an antibiotic, to make sure that they were responding. Also, this technique is very helpful when using delayed prescribing techniques. So if a patient is provided a prescription and told that if, when they're followed up within 24 to 48 hours, if their symptoms are still present or worsening, then they will be instructed to receive those antibiotics. A lot of clinicians are hesitant to use delayed antibiotic prescribing, if there is no support mechanism in place. So let's shift gears and really start then talking about vaccinations and stewardship. Again, I've already pointed out that one of the most important drivers related to receipt of an antibiotic is visit to a physician office rates. And from 2000 to 2001, when the pneumococcal conjugated vaccine was first introduced, we did know that there were reduced rates of invasive disease from 80 per 100,000 to 1 per 100,000. And as a result, one can extrapolate that the reduction in the number of cases then also correlated with the reduction of visits for pneumococcal infections. There were additional evidence to suggest that following the introduction of PCV13 and the pneumococcal polysaccharide 23-valent vaccine, that there were linkages between vaccination rates and invasive disease and possibly pneumococcal pneumonia. So again, all of these vaccines are quite effective in terms of preventing disease. So if we can prevent infections, we not only decrease the likelihood the patient needs to go to a physician's office, but the likelihood that they have to go there and receive an antibiotic for a potentially appropriate or inappropriate indication. And these data are just looking at, again, the trends in invasive pneumococcal disease among kids. And you can see the dramatic drop in the rates of invasive disease, both among the serotypes that were included in the vaccines and among all invasive serotypes. Additionally, I think this was somewhat astounding or interesting. When we look back at 2000, when the PCV7 was introduced, this first indication was among children and pediatrics. And we already noted that there was a reduction in the rates of invasive disease among kids, but there was also a protective effect among parents, and that parents appeared to have a decrease in the rates of invasive pneumococcal disease during that time frame as well. So even though the parents were not getting immunized, they were getting that protective effect since the children were not acquiring those types of infections. And you can see a general trend throughout 2015 that as we were introducing the new and expanded serotype vaccines, that there were declines in invasive pneumococcal disease among adults. So again, decreasing the need for visits, hospitalization, and antimicrobial prescribing. In terms of pneumococcal vaccine and additional effects on stewardship initiatives, there are data that revealed that the incidence of penicillin non-susceptible isolates that were resulting in invasive disease declined 64% in children and 45% among adults between essentially 1999 and 2008. So as the isolates in those serotypes are no longer affecting patients, those have been the ones historically that we had seen some of the resistance emerging. And when those serotypes were replaced by non-vaccine included serotypes, those tended to have improved susceptibility. So we did see a real impact on penicillin resistance rates or non-susceptibility rates among Streptococcus pneumoniae. Additionally, when we decrease the amount of invasive pneumococcal disease, we're likely to decrease the cost associated with treatment of those diseases. And back in 2004, there were 4 million cases of pneumococcal infections that were reported in the United States, which were associated with direct treatment costs of around $3.7 billion. So as we reduced the incidence of invasive pneumococcal disease, we're also likely to see a proportional decline in the direct costs associated to treat this condition. Now, unfortunately, like I mentioned, we're not doing a good job with respect to our vaccinations. So even among high-risk individuals aged 19 to 64 years of age, for the past several decades that we have data for, our vaccination rates are only about 20% of at-risk individuals, whereas our Healthy People 2020 target is 60%. So we're falling way short of that mark. Even among adult populations or elderly populations greater than 65 years of age, you can see that we've been kind of steady around 60% of that population receiving pneumococcal vaccination, whereas our target range for that population is 90%. So there is still a huge population of individuals out there that remain unvaccinated. If we shift a little bit and look at influenza, Influenza is a very difficult infection to manage. Predominantly from the standpoint that it's relatively difficult to diagnose on the clinician level. Using signs and symptoms alone of influenza-like illness, we know that from recent reports that the sensitivity associated with this symptom-based approach is no better than flipping a coin. And historically, clinicians have not trusted their diagnostic tools, and so they've been hesitant to order these point-of-care tests. Even when a gold standard such as PCR is used to confirm the presence of influenza, a lot of clinicians tend to ignore the data. In fact, in one study by Havers and colleagues, 30% of high-risk individuals with PCR-confirmed influenza received an antibiotic. Now, obviously, an antibiotic on the front end of influenza is not warranted. And we do know also that if patients do get influenza, regardless if they're treated appropriately or not, it does take a toll on their immune system and their host defenses, and these patients are at high risk for secondary bacterial pneumonia, very commonly caused by Streptococcus pneumoniae and Staphylococcus aureus. One study looked at the impact of vaccination on the acquisition of influenza and invasive pneumococcal disease. And they found that together, patients who received both the vaccinations reduced hospital admissions by approximately, and this is a typo, by about 32% for influenza, 22% for overall pneumonia, and 54% for invasive pneumococcal diseases, respectively. So again, the impact of vaccinations and the role that they have in terms of reducing diseases from occurring is quite substantial. But again, unfortunately, we're not hitting our mark. Influenza is, probably one of the vaccine preventable diseases in which we are, do the best job at promoting, since everybody needs to be revaccinated on an annual basis. But even for individuals greater than 19 years of age, especially with high-risk complications associated with influenza, and we're holding steady about 40% of that population being vaccinated, with our target range being about 70. And in terms of influenza, that would be the general population. And if we had a population where they had risk factors for complications, we do a better job hitting those people with vaccinations. We're at about 65%, but again, our target is approximately 90%. So we still have a long ways to go to improve the rates of vaccinations in those populations as well. So I'd just like to end by emphasizing that immunizations is a powerful tool for community antimicrobial stewardship programs. By preventing patients from getting infections or being able to say that they're less likely to have this infection caused by this organism can really improve our appropriate use of antibiotics. And not only can it have an impact on antibiotic use, it can improve antimicrobial susceptibility patterns and help contain treatment costs associated with directly treating these types of infections and the sequelae that result from them. I've got a few readings that have recently come out for those that might be interested in learning more about community antimicrobial stewardship and the role of vaccinations, and I've got those listed there. So with that, I can open the line up for questions.
Ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your touch-tone telephone. Again, ladies and gentlemen, if you have any questions, please press the number 1 key on your touch-tone telephone. We do have a question in queue from Donna BB. Please go ahead with your question. Hello, Donna. Your line is open.
I don't have a question. Not sure how I got in the queue.
Okay, ma'am. Again, ladies and gentlemen, if you do have a question at this time, please press the number 1 key on your touch-tone telephone. Okay, we do not have any callers in queue for questions at this time.
I do have one question for you, Dr. Klepser. So with all of this information and all of the things that are continuously coming at us for quality improvement and antibiotic stewardship and, all the other initiatives, how do you think we can best partner and have a collaborative mindset between pharmacists and providers and all the other healthcare professionals out there to use immunizations as a preventive tool?
Well, first of all, I think that there needs to be a general understanding that immunizations have multiple benefits, throughout the healthcare system. Not only, just are they effective at a patient level in preventing disease, but again, they can serve to reduce the number of unnecessary visits. They can serve to decrease the probability that an individual might, get an antibiotic, and then, downstream again, when we're decreasing antibiotic use, we're going to see improvements across the board. So really, there's, everyone from, any outpatient practitioner to even inpatient practitioners, have a interest or should have an interest in this type of operation. And probably what we need to do when we're talking about community stewardship or stewardship initiatives is really place vaccination initiatives front and center on there, and do a better job not only promoting antibiotics among our patients, but also taking the message about the safety and effectiveness to all patient populations regardless of age. Additionally, we need to do a much better job of tracking adult immunizations. Even in the state of Michigan, we have a wonderful online database that's managed by the state, where it's mandated that providers who administer vaccinations to children record all of their vaccinations for a given individual in that database. However, there is no such mandate to record adult immunizations. There's nothing that prevents them from doing that, and many clinicians are recording them. But if I have a patient that has gone to a pharmacy and received a vaccination, if that pharmacy did not enter the fact that that adult patient had gotten the vaccination, I may again try to vaccinate that patient, in my setting. Likewise, it needs to be, one of the primary questions that are asked every time a patient, is seen by a physician, or perhaps even in a pharmacy visit, is to double check and do a, reconciliation of their vaccinations to determine whether or not they're, a candidate for those vaccination programs. So really it's a multifaceted approach that needs to be taken, but it doesn't necessarily have to be something that, gets put on one entity or another. There just needs to be a coordinated effort of education and recording. And one of the primary recommendations has always been that if a patient is willing to get a vaccine, they need to be able to get it. So taking down barriers that prevent any individuals across the healthcare system from administering a vaccine to a patient when they're willing to receive that vaccine is also going to be important.
Thank you. Yeah, I think there's a lot of work that can be done, so I'm excited to be a part of that. Were there any other questions, operator, in the queue?
No, ma'am. There are no callers in the queue for questions.
Okay. Well, today's slides will be available on our Lake Superior QIN YouTube page within the next week. At this time, let's pull up the evaluation questions, which should be up there, hopefully. Please take a moment to let us know how we did by filling these out. Thank you for joining us today for our webinar on immunizations and antibiotic stewardship. And thank you again to Dr. Klepser for speaking with us about this topic. As a reminder, the slides will be available within the next week. Additionally, we wanted to let you know that MPRO is offering an initiative to implement the core elements of outpatient antibiotic stewardship, including educational opportunities and direct technical assistance to participating facilities. So please contact us if you would like more information on that specific project. If there's nothing else, we thank you for joining us today and hope you have a great rest of your day.
Thank you.
Thank you, ladies and gentlemen, for joining today's call. You all may disconnect this time and have a good day.